Hello everyone! We have finally reached the end of our course. So this is our very last lecture. It is the third module of chapter 16 and it is definitely shorter than the others, so hopefully it shouldn't take too much time to get through. I know that the module on the different types of therapies, module 2, ended up taking a lot more time than I had anticipated, so I wanted to keep this one short and sweet for you. So we are going to talk about a few of the different types of drug treatments that are used for psychological disorders, and we'll talk a bit about some other types of medical treatments that can be used, such as electroconvulsive therapy and certain types of brain intervention. So, Module 3 is called Biomedical Therapies. So the biomedical approach to treating psychological disorder involves using drugs, surgery, or other medical procedures to alter the functioning of the central nervous system. So anytime we're using something that basically kind of comes from the realm of medicine or involves, technology, direct intervention into the brain or the nervous system, that would be considered a type of biomedical therapy. So psychopharmacotherapy is the use of drugs to manage or reduce client symptoms, and it is by far the most frequently used biomedical option. So antidepressants, anti-anxiety medications, all of those things are very commonly prescribed, and so the psychopharmacology perspective or treatment is definitely the most common type of treatment from this section. However, it is often used in conjunction with some form of psychological therapy as well. So typically, they will recommend that a person not only take, say, antidepressant or antipsychotic medication, but they also engage in some kind of talk therapy as well. Other options, such as surgery or electroconvulsive therapy, are typically only used in cases where no other available treatments have succeeded. So typically those types of treatments are only going to be used if absolutely necessary. But we will talk about a few of them and how effective they have been. So in terms of our drug treatments, psychotropic drugs is basically just a general term that describes medications designed to alter psychological functioning. So we talked a lot about psychoactive or psychotropic drugs when we talked about the consciousness chapter. We discussed a lot of the different types of drugs you can take, like stimulants, depressants, opiates, and hallucinogens. So psychotropic drugs is kind of just a general term. Any medication that will alter your psychological functioning. Drug approaches to treating psychological disorder were first typically used in institutional and clinical settings, and they were generally used for targeting severe cases. In recent decades, they have become more mainstream practice. So these days, basically psychotropic drugs or kind of drug treatments for mental disorders, psychological disorders are very commonly used. Psychotropic drugs are designed to be able to cross the blood-brain barrier, which is a network of tightly packed cells that only allow specific types of substances to move from the bloodstream to the brain. So basically it protects the brain, the delicate brain cells, against harmful infections and other substances. So only certain substances are allowed to cross that barrier. Once the drugs cross that barrier, they affect one or more neurotransmitters within the brain. So now we'll talk a bit about antidepressants. So antidepressant drugs, as the name implies, are medications designed to reduce symptoms of depression. There are several types of antidepressants. So the first type of antidepressants to be developed were known as monoamine oxidase inhibitors, or MAOIs. They were drugs that worked by deactivating an enzyme known as monoamine oxidase. So basically that enzyme broke down serotonin, dopamine, and norepinephrine in the synaptic clefts of the nerve cells. So basically after it had its desired effect on the postsynaptic neuron, it will be broken down instead of kind of taken back up. And so basically what this drug did was stop the enzyme from breaking them down, so therefore there was more serotonin, dopamine, and norepinephrine available at the synapse. They're now used less frequently than others, so unfortunately they did come with a host of dangerous side effects, especially when they interacted with other medications and even certain types of food. So even things like aged cheese, smoked meat, and alcohol could have kind of really negative interactions with MAOIs, so they're not really commonly used anymore. Another type of early antidepressants were known as tricyclic antidepressants, and they appear to work by blocking the reuptake of serotonin and norepinephrine. So a similar kind of function within the brain, effect within the brain. They're still working on serotonin or epinephrine, but they're basically just stopping them from being taken back up into the presynaptic neuron instead of stopping them from being broken down. But still, the net result is to increase the amount of serotonin and norepinephrine available. And then finally, we have selective serotonin reuptake inhibitors, or SSRIs. You've probably heard that phrase before. I'm sure I've mentioned it in class. They're a class of antidepressant drugs that block the reuptake of serotonin. So very similar to tricyclic, but they're focusing specifically on serotonin. They possibly take effect by either reducing the overall arousal level of the person or decreasing activation in the amygdala, which we know is associated with some negative emotionality. So at any rate, regardless of how they take effect, SSRIs are probably the most common type of antidepressant prescribed today. They're newer and they tend to have less negative side effects than some of the others, although of course there are always potential side effects with any drug that you could take. Next, we're going to talk briefly about something called St. John's wort. So you may have heard of it before. It's a herbal treatment that can be found in many health food stores and pharmacies. It does actually appear to influence several of the neurotransmitter systems that are altered by traditional antidepressant medications. So it does seem to have some impact on levels of serotonin and epinephrine in the brain. Research using animal participants has shown St. John's wort to reduce a number of behaviors linked with depression and anxiety, and a recent meta-analysis of its effects on human participants found that it did lead to reduced levels of depression when compared to placebos. So it actually did seem to be essentially about as effective as other antidepressants. However, our main concern here is that St. John's wort is not standardized or carefully regulated by government agencies, and it may interact negatively with other drugs. Specifically, it has been known to have negative interactions with other antidepressants, so it's definitely, even though it's shown some promising results, it's not something that we are going to kind of recommend for use at this point. There still needs to be more research done and more standardization before it could be kind of recommended as a treatment. Next, we'll talk briefly about mood stabilizers. So we talked about antidepressants, which are used primarily for what we call unipolar depression, which would be depression that only consists of the depressed moods, whereas bipolar would be the depression and the mania. So mood stabilizers are typically used to prevent or reduce the severity of mood swings experienced by people with bipolar disorder. So now we're not focusing just on depressive symptoms, we're focusing on kind of the swinging back and forth between the depressed mood and the manic mood. One of the first mood stabilizers to be prescribed regularly in psychiatry is lithium carbonate, which is essentially a salt compound. And from the 1950s to the 1980s, it was the standard drug treatment for depression and bipolar disorder. So it was very commonly used for a long period of time. It has been shown to be quite effective for treating these disorders, but it can also be very toxic to the kidneys and the endocrine system. So the problem with lithium carbonate is that it has a very small, what we call a therapeutic window, which is the amount that you need for it to actually have an effect, but not be kind of too much of it. So if you use too little lithium carbonate, it's not going to have any impact. If you use too much, it can have really negative impact. So today, doctors generally prefer to prescribe other drugs to treat bipolar disorder, such as anticonvulsant medications or antipsychotic medications. Now we'll talk briefly about anti-anxiety drugs. So the name anti-anxiety implies that they're what we use primarily to treat anxiety disorders, but if you're talking about long-term treatment of anxiety, such as generalized anxiety disorder, typically that's actually treated with an antidepressant. Anti-anxiety drugs, often referred to as tranquilizers, they're actually meant to be used in kind of the short term, not something that you're hopefully having to rely on every single day constantly. So they affect the activity of gamma-aminobutyric acid, or GABA, which is our primary inhibitory neurotransmitter in our brain that reduces neural activity. So basically, as you can kind of imagine, if it's an inhibitory neurotransmitter and it's kind of impacting and magnifying the impact of that neurotransmitter, it's going to help us kind of slow everything down and reduce, panic and things like that. So these drugs are prescribed to alleviate nervousness and tension and to prevent and reduce panic attacks. These drugs appear to temporarily alter the structure of the GABA receptors, but their effects are unfortunately relatively short-lived. So they tend to take effect fairly quickly, but they also don't tend to last for a super long period of time. Anti-anxiety drugs, for example, lorazepam, which is also known as Ativan, Ativan, clonazepam, which is known as Klonopin, diazepam, Valium, and alprazolam, Xanax. They can have serious side effects, and they do come with a risk of abuse and withdrawal. You've probably heard of people abusing drugs like Xanax and Valium before. So their prescription is regulated. So for example, a lot of walk-in clinics, if you go to a walk-in clinic, they often have signs up saying that they won't prescribe benzodiazepines, which is what these drugs are part of a class called benzodiazepines, and they won't prescribe them to walk-in patients typically because they are kind of pretty strictly regulated. They have a really high potential for abuse or kind of addiction. Now we'll talk briefly about antipsychotic drugs. So antipsychotic drugs are generally used to treat symptoms of psychosis, including delusions, hallucinations, and severely disturbed or disorganized thought. So these drugs are the common treatment for disorders such as schizophrenia, and they're sometimes prescribed to people with severe mood disorders as well, as we kind of mentioned on the slide where we were talking about the mood stabilizers. So the first generation of antipsychotic drugs was designed to block dopamine receptors. Some psychotic illnesses such as schizophrenia have been associated with kind of overactive dopamine receptors, but they had severe side effects including tardive dyskinesia, which is a movement disorder involving involuntary movements and facial tics. So the first generation of antipsychotic drugs, they tend to kind of help out with the disorders they were designed to treat, but they came with a lot of really negative potential side effects. Newer antipsychotics are referred to as atypical antipsychotics. They're less likely to produce the side effects, including movement disorders, that commonly occurred with the first generation antipsychotics, but they still carry some risk because, again, whenever we're talking about any type of drug therapy, there's obviously some amount of inherent risk. So, for example, some of the newer antipsychotics may be at risk of compromising immune system functioning. So, a lot of the time these types of drugs are only prescribed when really deemed necessary. The benefits outweigh the costs. In terms of evaluating drug therapies, people commonly believe that drugs are designed to target the root physical causes of psychological disorders and should therefore be more effective than psychological therapies. So a lot of people would say, well, you know what, if it's actually affecting kind of the biological origins of the disorder, then it should be very effective in helping to treat it. But these beliefs aren't really warranted. In many cases, drugs are not more effective than psychological therapies. So for example, with antidepressants, we see that about 50 to 60% of patients improve in terms of their depressive symptoms when they start using antidepressants, but actually 30% of people improve just using a placebo. So, about half the amount of people would improve regardless of whether or not they were using the actual antidepressant drug. And we see that 50 to 60% of people also improve with therapy. So around the same amount of people show improvement with therapy as do with the antidepressant drugs. So for anxiety disorders, psychological treatments such as CBT are generally the most effective treatment. We see that the effects are longer lasting. So as we talked about with anti-anxiety medication, those effects are typically short-lived. But if you're able to use something like cognitive behavioral therapy to actually help change somebody's thought patterns, kind of get to the root of the problem, then those effects tend to be much longer lasting. So in many situations, a combination of treatment approaches may work best. Depression, anxiety disorders, and even schizophrenia, it's really good to have the combination of both the therapy and the drug treatment. And even disorders that are generally viewed as predominantly biological, such as schizophrenia, are better understood from a biopsychosocial perspective. So we have to keep in mind that we shouldn't just focus on the biological aspects. We should take other situational and psychological factors into account as well. So that's it for drug therapies. Again, like I said, it's not a super long module. Now we're going to talk very briefly about some of the technological and surgical methods that have been used to treat psychological disorders, and then we are all done with chapter 16. So, technological and surgical methods. You've most likely all heard of the frontal lobotomy, which is surgically severing the connections between different regions of the brain. I'm sure that as soon as you hear the word lobotomy, it kind of comes with a negative connotation, and really it should. There were a lot of really negative outcomes involved with lobotomies, and they are not used in the same way they were in the past. These days they're disallowed. So a Portuguese surgeon named Antonio Moniz developed a technique known as the leucotomy, which involves surgically destroying the brain tissue in the prefrontal cortex. An American surgeon named Dr. Walter Freeman then took this technique and popularized it, naming his version the lobotomy. So the lobotomy that you've probably heard of, if you think of kind of the classic ice pick lobotomy, where they kind of go in through the eye socket and up into the brain, that was the technique that was kind of popularized and used by Dr. Walter Freeman. And he actually performed thousands of lobotomies, and he kind of traveled the country teaching other people, other psychiatrists and doctors, how to perform lobotomies, and eventually he was stripped of his right to practice in 1967. So by the 1950s, the popularity of the frontal lobotomy was dwindling rapidly due to its inconsistent and often negative results, but nonetheless, the basic practice of therapeutically destroying brain tissue survives to this day, although at this point it is much more refined and precise. We're much better able to intervene in the brain in less damaging ways that still help out with symptoms of the various disorders that we talk about. So with respect to some of the newer types of, medical or brain interventions that we use to treat psychological illness, two of them are focal lesions and electroconvulsive therapy. So focal lesions are small areas of brain tissue that are surgically destroyed. They're only used in severe cases when all other treatment has failed. One example is known as the anterior cingulotomy, which targets a cluster of brain cells in a brain area known as the anterior cingulate cortex that basically helps treat severe depression and anxiety disorders. It actually has been shown to have no more risks or side effects than do many of the drugs that are used to treat these disorders. So focal lesions can be used effectively with relatively few risks and side effects to help treat things like severe depression and anxiety. Another example is electroconvulsive therapy, or ECT, which you've probably heard of before, and it does have a negative reputation. You've seen it maybe in movies where they use it to kind of shock the patients, and it looks very traumatic and kind of very dangerous. But in reality, the type of ECT that we use today is relatively safe and has relatively few side effects. So it involves passing an electrical current through the brain in order to induce a temporary seizure. It was introduced in the 1930s, but over the years, techniques have been improved dramatically. Still, it is reserved for the most severe cases of disorders such as depression and bipolar disorder, for which it has been found to be quite effective. So again, none of these medical interventions are used as frequently as the other techniques. They're typically used as kind of a last-ditch effort to help out where nothing else has been effective. Then we have repetitive transcranial magnetic stimulation. So repetitive transcranial magnetic stimulation, also known as RTMS, is a therapeutic technique in which a focal area of the brain is exposed to a powerful magnetic field across several treatment sessions. So basically we're using a magnetic field to target specific brain areas, and that magnetic field can either stimulate or inhibit activity in particular brain areas, such as the left prefrontal cortex. So in cases of depression, which are obviously associated with kind of more negative moods, if you stimulate the area of the left prefrontal cortex, which is known to be involved in positive emotion, that can help kind of create more positive emotion in those patients. Or also we can use RTMS to try to inhibit areas in the right prefrontal cortex which are associated with negative emotions. So that can kind of help out in the treatment of depression. RTMS does not have immediate effects. Treatment typically involves between 10 and 25 sessions with follow-up appointments every few months. So it's something that you are going to have to kind of commit to for a longer period of time. It doesn't work instantaneously, and it does require kind of follow-up appointments to kind of keep its effects. RTMS, however, does have a number of advantages over other treatments. There is no need for anesthesia, there is no induction of seizures, and there are no known associated cognitive impairments, and it may hold considerable promise for reducing symptoms of disorders such as depression and schizophrenia. So we know that it has been proven somewhat successful at least in treating depression, and it may actually be able to treat other severe disorders as well. Finally, we have deep brain stimulation. So deep brain stimulation, or DBS, is a technique that involves electrically stimulating specific regions of the brain. A thin electrode-tipped wire is inserted into the brain and carefully routed to targeted brain regions. So it's very, very kind of specific in what it's stimulating. Unlike many drugs and other treatments that we've already discussed, DBS produces instantaneous results and seems to work for even severe cases of depression that have not responded to any other treatment. It has also been shown in studies to help with symptoms of OCD as well. However, as with every other technique and drug that we've talked about, this technique does not come without risk. So for example, it may cause internal bleeding and putting the wires when they're inserted into the brain, or infection, and it also comes with more benign but kind of interesting potential side effects such as spontaneous laughter and spontaneous penile erection. So it's one of the better techniques in terms of the biomedical techniques that we've talked about, but still has some possibility for negative side effects as well. There are many other techniques that we didn't cover here that are still in development, and there have been many innovations made in gene therapies, neuroimaging, neurostimulating, and computer science, which are sure to provide our patients with a number of high-quality treatment options. So in summary, for the end of the chapter and actually the end of our course, the future of psychology is exciting. We've come a long way. As we've talked about even way back in chapter 1, psychology is a relatively new science, and it's come so far in the past 150 years, and we have even further to go. So that basically concludes our course. We are finished, and I hope that you enjoyed it. If you have any questions, don't hesitate to reach out to me. Obviously, I'm here anytime now, between now and our exam on the 13th of April. So the exam will be held on the 13th at the time that it's scheduled for. The only difference is that it's going to be online. So you're going to log on to Moodle, and you're going to go to our quiz page where you did our psychology quizzes. By the way, Chapter 16 is opening after class tomorrow, which is Friday, the 3rd of April. And so you're going to go on that exact same page that you go to do those quizzes, and you're going to see a test that's labeled the final exam for our course in my name. And you're going to log on exactly at the time that it's scheduled to happen, and you're going to be given an hour to answer 50 multiple choice questions. So that will be the format for our final exam. If you have any questions, please let me know. And I'm not sure about posting a review guide, because typically I focus the review guide on short answer questions, and we don't have any on this exam. But honestly, as long as you have kind of followed along with these lectures and you keep all your kind of important terms in mind, really, because it is all multiple choice, it will be focused primarily on the bolded terms that are in the notes, then you should be fine for our exam. So thanks for listening, and I hope you all have a wonderful end of the semester. I hope to hear from some of you, and please let me know if you have any concerns or questions. Have a great night, day, whatever it is when you're watching this.